Good morning, afternoon, and evening. It's Tuesday, April 14th, 2020, and on behalf of everyone at Simulations Plus, welcome to GastroPlus Day 2 Special Population Predictions with Dr. Viera Lukacova. For optimal video and audio connection, we highly recommend you close any additional web or streaming applications that may affect your internet bandwidth. This call is being recorded, and today's course structure will have lecture and live examples, followed by a very lively Q&A session. Have your pencils and paper ready. It's going to be an educational 90 minutes. Now, before we get started today, we have a quick poll question. How would you classify your experience with GastroPlus software? We'll give you about 30 seconds to submit your answer. Few more seconds here. And the poll is now closed. Now it is my pleasure to introduce today's moderator, Mr. Dan O'Connor, Director of Business Development for Simulation Sciences. Take it away, Dan.
Good morning and good evening and good afternoon wherever you are, and thank you, Arlene, for the introduction. And welcome to all of the attendees on day 2 of our workshop from home seminar series for GastroPlus. Yesterday we had an astounding level of attendance for the introductory course, and over the next 4 days we will be highlighting individual segments of the capability of GastroPlus, today being special population predictions. Just a brief introduction to a recent announcement that happened just about 2 weeks ago was the addition of the Lixoft company to the Simulations Plus family of companies. As many of you probably already know, Lixoft develops modeling and simulation software for advanced population analysis, pharmacometrics, and preclinical and clinical trial modeling and simulation. And what that does is it adds another additional layer of software and consulting solution to our already pretty neat complement of offerings, both software and consulting that we offer. So that's kind of the idea of what we're doing today, trying to offer you, the attendees, a little bit deeper dive into the utility of some of the tools, in this case specifically GastroPlus. It's now my pleasure to introduce Viera Lukacova, who's the Director of Simulation Sciences here and will be our presenter this morning. Viera received her PhD in Pharmaceutical Sciences from North Dakota State University. And for the last 15 years or so, in addition to supporting hundreds of client modeling studies, Viera has been guiding the development of our 3 primary software platforms, those being DDD+, which allows for the modeling of in vitro dissolution of APIs and excipients, Membrane+, which is our in vitro permeability and hepatocyte modeling software, and lastly, why you're here this morning, for GastroPlus. Viera is an expert who is frequently called upon by regulatory agencies worldwide. As a matter of fact, I think we have meetings with a regulatory agency this week. And they invite her to inform, train their reviewers on the utility, the value, and the next generation development of modeling and simulation. So without further ado, it's my pleasure to introduce Dr. Lukacova.
Thank you, Dan, for the nice introduction. Good morning, good afternoon, everyone, to this webinar where we are going to talk a little bit more in detail. And well, let me make sure I'm showing the correct screen. You should be seeing the slides. Good.
We are.
So today we will be talking a little bit more in detail about modeling special populations in GastroPlus. During today's presentation, I will go over a few slides of basics of PBPK modeling, what is the general structure of the model, and especially the model within GastroPlus. And then we'll go into how these models can be adapted to model different populations. Pediatrics, we'll look into some of the disease conditions that we have incorporated in the program, and as well as our latest development, the modeling in pregnancy, modeling of PK in pregnant women. So to get right into it, I'm sure you've seen this picture. Those who attended yesterday, you've seen this picture in yesterday's webinar, and those who will be attending the next 3 days will probably see this picture over and over, showing the general structure of the model within GastroPlus. The big focus here is the gastrointestinal tract, looking at how the drug would be behaving after oral administration. And this can then be linked to either the simpler compartmental pharmacokinetic model or a full PBPK or physiologically based model. So today we will focus a little bit more on this PBPK section, looking at the changes in the physiology in different conditions in different populations. The gastrointestinal tract is always linked there, and any physiological changes that are happening in these conditions are accounted for on the gastrointestinal tract as well. So this is the general structure of the PBPK model, and those of you who've read, even one paper on PBPK modeling probably have seen a similar schematics for the structure of the model. It may seem a little intimidating, but just think of it as a series of compartments. Those are these different boxes. And with the PBPK model, these compartments represent individual tissues in the body. So we've got a compartment for lung, liver, heart, brain, muscle, and so on. The blue arrows are showing the blood flow through the tissues, which is distributing the drug through the individual tissues, carries it, and also responsible for elimination of the drug. So each one of these boxes represents a specific tissue which is characterized by its own physiological size, physiological volume, blood flow, expression levels of enzymes and transporters are responsible for the drug distribution or elimination, composition of the tissue, which determines the types of molecules that are going to be preferentially partitioning into different tissues, and so on. And these tissues, these different compartments within the model can have different types of models, or the distribution of the compound in these compartments can be described by different types of models. The simplest ones are representing the blood compartments, venous and arterial blood. And these are considered currently to be well-mixed compartments, where you can account for binding to the red blood cells and plasma protein. Right? And these are currently assumed to be simple linear non-saturable processes in our model. But you can also have elimination of the compound directly in the blood. So beginning with 1 or 2 versions ago, you now can add a clearance directly into the blood, something that we have seen occurring even in our studies more and more, and maybe important aspect. For all the other tissues, the general description for the tissue structure is splitting any tissue into 3 subcompartments. You have a blood flow through the tissue, representing the vascular space, and then the tissue itself can be split into cells, the intracellular space, and the extracellular or interstitial space. And depending on the processes governing the drug distribution throughout the tissue, this model can be further simplified by lumping this extracellular space and the cellular space into a single compartment. Right? And this would happen in case where the drug is moving across the membranes very quickly, So it equilibrates quickly between extracellular and cellular space. There are no issues with the transporters or anything like that. The model can be simplified to only two-compartment model where we have a blood flow and the tissue space. And here I need to point out that these schematics that you will see are not to scale. The blood flow or the vascular space is generally a very small fraction of the entire tissue space. So for these perfusion-limited tissues, the parameter that we use to describe the distribution of the drug between the blood or between the plasma flowing through the tissue and the tissue itself is the Kp, or the tissue plasma partition coefficient. And this can be generally predicted from tissue properties, from the composition in terms of amount of protein, lipid, water in the tissue, and the compound properties like lipophilicity, ionization, plasma protein binding, red blood to plasma concentration ratio. For the compounds that have a little bit more complex mechanisms involved in distribution between the extracellular and cellular space, we do need to model or use the full three-compartment model here to account for either slow diffusion of the drug between the extracellular and cellular space, and this is generally parameterized by permeability surface area product, or we need to account for any influence of transporters that are either bringing the drug into the cells or causing the efflux of moving the drug out of the cells. And for the transporter effect, we are using Michaelis-Menten kinetics, requiring specification of K and Vmax values and the transporter expression levels in the relevant tissues. Two tissues have a little bit more extensive description, and one of them is liver, where in addition to modeling the processes on the basolateral membrane, so what was described in here, this portion would be considered the basolateral membrane, bringing the drug between the blood and the hepatocyte. We also need to model the other side of the cells, the canalicular or apical membrane, for the drug secretion into the bile. And here we have an option to use simpler or more complex description depending on what stage of the drug development you're at, how much information you have. You could describe the drug getting into the bile either as a simple fraction of the drug being cleared by the bile. Right? This is something that you might be getting estimates in the very early stages. Could use possibly a simple flux, non-saturable process, or can go all the way into modeling it through transporters and possibly saturable efflux of the drug from the hepatocyte into the bile. The other tissue where we have the more extensive description is kidney tissue to account for the drug secretion into the urine. So here we have additional process incorporated for the drug filtration in the glomerulus, drug getting from the blood directly into the kidney tubules, and from there through urine flow the drug gets eliminated from the body. But we also do have additional processes for the drug exchange between the kidney tubules and the tissue itself to account for possibly additional passive or transporter-mediated drug secretion or reabsorption from the kidney tubules. For the simple glomerular filtration, we provide you with several different methods to estimate this based on the physiological and drug properties. The one that physiologically makes the most sense, FUP times GFR, would be the default method. And if you are seeing that the FUP times GFR is not predicting correctly the amount of drug that you are seeing in urine and either animal or clinical studies, this is generally an indication of additional processes happening here. So if FUP times GFR underpredicts the amount of drug getting into urine, you are dealing with compound which has also significant portion of active secretion or transporter-mediated secretion into the tubules. Or if it's over-predicting the exposure, that means the drug is actually being reabsorbed from the tubules back into the body, so the urinary secretion is not as efficient as would be predicted by the glomerular filtration rate. A brief note on how these physiologies are characterized within GastroPlus. And, to define the physiologically based model, there is a lot of physiological information required to parameterize the body and to parameterize the properties of individual tissues. Right? Things like tissue size, like weight, blood weight and volume, blood flow through that tissue, density of the tissue, composition, and so on. To parameterize this, GastroPlus includes built-in physiologies for human, for 3 different populations. Currently, we have a Western physiology, Japanese, and Chinese physiology incorporated in the model. And for human, you have full range of specific physiologies for different subjects that you can create for different genders, males, females, or different ages, going anywhere from 16-week premature newborns up to elderly. I think our cutoff is currently about 85 or 90 years old. To help with the first-in-human predictions, so on the early stages of the drug development process, we do also incorporate a variety of physiologies for animals. We are covering all the commonly utilized animal species in the drug development process: mouse, rat, dog, monkey, rabbit, guinea pig. But for the animals, these are currently representing male adult animals. So we don't have juvenile physiologies for animals yet, but it would be coming in future versions. The first-in-human prediction, however, is not a main focus today. We are going to be talking more about special populations, so we'll be discussing more the different settings for human physiologies and how to adapt them to different populations. This is just a small snapshot of the different data that we've used to create those default physiologies. For example, this one is showing how we're parameterizing the general demographics in terms of body height and weight for different subjects and different ages. These plots are showing one of our validation cases to make sure that our population simulator, which we'll look into a little bit later today, is able to generate a population that actually represents a general population. And this one was trying to represent the American population based on the NHANES survey. And what you see is body heights over body weights for males and females. And in each plot, let's say on the males, the dark points are showing the actual observed or the actual demographic from the NHANES data set. And the light blue points are showing the population that would be generated by our population simulator. And as you can see, it is able to nicely represent the whole population in US, as well as for males, as well as for females. Similar plots going into younger subjects, and this is going from 1 through 20 years old. Again, you can see our population simulation is able to nicely capture the variability in the population here. And finally, I mentioned that we can model the neonates and infants as well. So this is showing the similar plots for infants up to 1 year old. Of course, for building the PBPK models, it's not only about body height and weight, but it is mainly about individual tissues, right? And I'm not going to go through every single tissue. This is just an example of information that we've used, collected from literature, to characterize how the tissue sizes, how the tissues are growing with age as the child starts growing and turns into adult. This one is showing for adipose tissue, this one is for liver weight, and similar information and plots could be generated for all the other tissues within our PBPK models. The blood flows, again, just a quick example of the information we found in the literature, helping us to characterize the rate of blood flow through every single tissue in the body so that we can correctly account for the distribution. So a lot of information that goes into creating the PBPK models, but of course for you as a user of GastroPlus, it's not as complicated or as difficult because everything is built into the program. So when you try to create a physiology for a specific subject, All you need to do is decide what subject you want. Which species do you want? Do you want human or any of the preclinical species? If it is human, you select which population you want to sample from, and this is the American or Western population, Chinese or Japanese. Do you want a physiology for male or female? Do you want to create a physiology for healthy subjects or any of those, any of the disease conditions, or possibly a pregnant female? What age should be do you want to represent? And as I mentioned, if you are going for infants less than 1 year old, you can also account for the effect of gestational age. Was this baby born at term or was it premature? And you can go as low as 16-week premature here. And based on this specification, the program will generate what a typical physiology, what a typical subject from that population, gender and age would look like in terms of body height, weight, BMI, and the individual tissue compositions. You still have additional freedom here to make modifications. So let's say if the program says that typically that right now in US, typical 30-year-old American male would be about 85 kilograms, but you are doing a study where you are controlling it a little bit more and your average are 75 kilograms, or you are controlling the subjects based on BMI, you can modify these parameters and have the physiology scaled to the appropriate specification of the subject that you are trying to simulate. So that was a very general overview, very quick overview of the PBPK models within GastroPlus. And now we'll start looking a little bit more about what we are doing with those individual, what we call special populations. And the first one we'll start with are the pediatrics. So looking into modeling of PK in children. And for the older children, I already showed some of these plots. It becomes fairly straightforward describing the physiologies, where these descriptions or characterization was a little bit more complex was when describing the infants. The first year of life, where the changes are very quick. Those of you who have kids, you went through this stage where your baby looks very different from one day to the next, and it's not just in their behavior; it's also in their physiology. Right? So this is where it becomes important to really well capture these rapid changes. For some of the tissues, it is just the simple growth of the baby from going from fetus up to when baby is born, and the tissues keep growing in a monotonous fashion. But it's not that way for every single tissue. For some tissues, the gestational age versus postnatal age does make a significant difference, and the growth pattern changes after birth. The additional aspects that change are the compositions of the tissues, how much water, how much lipid is in tissue. And here is just an example of two of the tissues, but we have similar relationships built into the program to account for the changes in the tissue compositions. And one that I wanted to point out was, let's say, adipose tissue, considered to be a fatty tissue, but not so much in the babies, especially the ones that are born premature. The very young premature baby, even the adipose tissue is mostly water. Those babies are water, but very quickly it starts turning more into the lipid fractions, and in adulthood, that tissue has less of the water and more of the lipid fraction. So this is something that also needs to be accounted for to account properly for changes in the drug distribution into different tissues. So accounting not only for clearance, but also distribution into different tissues. The other parameters that are changing are blood composition, the protein levels in the plasma, and hematocrit or red blood cell fraction in the blood are also changing with age. And again, the biggest changes are observed within the first year of life. And we do incorporate a scaling of the blood to plasma concentration ratio and FUP to account for these changes as you are moving between predicting adults and children of different ages. This is the equation that we are using for scaling fraction unbound in plasma for children based on the changes in the plasma protein levels. And this is a validation case showing what would be the predicted fraction unbound in children using this equation and what was the actual observed fraction unbound. Hematocrit, also the first two plots here are showing example how the protein levels are changing within the plasma for those children. Again, here we are looking at the first year of life, starting from 24 weeks of gestation, so the premature babies up to the first year of life. And you can see that within the first few weeks, there is significant change in the protein levels, but by about 1 year, they are getting close to adult. With hematocrit, again, significant and rapid changes for the first few weeks after birth, and then slower uptake until it reaches the adult levels later in the childhood. The clearance is accounted for the built-in expression levels for some of these where the ontogeny is known. We are accounting for the changes or how the expression levels in different tissues are changing. This slide is highlighting some of the 3A4 enzymes where for the babies, for the neonates, the 3A7 is the dominant enzyme here having the highest expression. But within the first year of life, the 3A7 is going down and is becoming replaced more by 3A4. About 6 months old, they have similar expression, similar activities. By 1 year old, the 3A4 becomes the dominant enzyme. And by about 5 years old, the 3A7 has minimal contribution, and the 3A4 in liver basically reaches the expression levels in adults. The intestinal expression is changing in a little bit different rate, at least based on information that was characterized, that was available in literature. It seems that within the intestine, the maturation is a little bit slower and takes a few years before it reaches the adult levels. Okay. So to show you a very quick way of setting up the physiology for children or doing the PBPK prediction for pediatric patients, I have here first example, our favorite compound, midazolam. We will use it for all of our examples, where I've already created a model basically doing a prediction of PK for midazolam based on in vitro properties and in vitro measurements of Km and Vmax values for midazolam by 3A4. For those of you not familiar with this compound, it is nearly exclusively metabolized or eliminated by 3A4 metabolism, which has significant expression in the intestine as well as in liver. So our first step is typically starting with validating the model by predicting PK in healthy adults. And here we have a model, standard PBPK model with the 3A4 enzymatic clearance. And this first simulation is showing prediction. And this is actually first in human prediction based on in vitro data after 5 milligram intravenous administration in healthy adults. And it is a very reasonable, good first prediction. Using the same model, we are now going to predict what that PK would look like after oral administration in adults. And I'll do just one of these doses for 15 milligrams. We are doing a solution administration and using the same physiology, the same parameters for the IV dose. You can see that the oral administration is also predicted nicely for adults. So this is the first step before you go into the special populations, whether it's pediatrics or any of the other disease conditions. It is best to validate that your model is predicting well the healthy subjects to make sure that you are correctly understanding and representing the mechanisms that are affecting the PK of the compound. So now I want to start predicting this pharmacokinetics in children. I have an adult model, so the easiest way to start the prediction is to make a copy of this record. And for children, we have data for oral administration, so I'll make a copy of this PO record for oral administration in adults. Database copy drug record, right? So that I can get an identical copy of it, and I will call this record pediatric PO solution 2.2 milligram. And okay. It was a oral administration with 2.2 milligram dose, so we'll adjust the dose here, right? 2.2, or actually it was 0.1 milligram per kilogram. One thing to keep in mind if you are going into pediatric, make sure the dose volume, which I think Maxine was describing yesterday, is correctly represented. The average child in the study that we will be modeling here was about 5 years old, and it might get difficult to get a 5-year-old child to drink, full 250 mils of water in one sitting. So make sure to adjust these. We'll go to about 50 milliliters, right? The next change that we need to make is adjust our physiology, create a physiology for that 5-year-old child. So we'll go into new PBPK. It is still a human. We'll keep American population, male, healthy in this case, and we simply set the age to 5 years. And the program automatically tells me that the average body weight for a 5-year-old American male would be about 20 kilograms, BMI about 16, and this would be the individual tissue blood flows and volumes. And at this point, if you do have different specification, maybe you are trying to model PK in sick children, they will be a little bit lighter, right? Or might be lighter than typical children, you can simply adjust the body weight, and the program automatically rescales everything to account for the smaller child if you need to model that. If you are looking at the obesity in pediatric population, right, all you need to do is increase the body weight. The program recalculates all the specifications, including the specifications how the different tissue sizes would be changing in this population or in this subject. In this case, though, our study or our typical body weight was actually close to the average body weight in the study, so we'll keep just the standard physiology. Click OK. The program suggests the name for the physiology. For this file, you can give it any name you'd like. I typically keep the descriptive physiology that GastroPlus suggests, right? Because it helps me to identify later on what that physiology represents, and I will always know that this was a healthy male, 5 years old, about 20 kilograms. As we described, there are still some changes also in the hematocrit, even though by 5 years it's getting close to the adult levels, right? So there would be some change in blood to plasma concentration ratio. The plasma protein levels are also getting close to adult. We are at 92% of the adult values, but again, still small change that would be causing a difference in the tissue distribution. So at this point, I would want to recalculate the KPs, or the tissue plasma partition coefficients, to account for these changes in the physiology. And I'm ready to start doing a prediction. If I have an adult model with properly characterized mechanisms, all I need to do is change the physiology. And the physiology in the all the tissue sizes, blood flows were scaled, right? If I look into the liver tissue and the enzyme expression levels, I can see here the program is telling me for 3A4, which is the metabolizing enzyme for this compound. We do have pediatric levels, so this enzyme was automatically scaled. The expression level in the liver was automatically scaled to a 5-year-old child. The same applies to the enzyme expression levels in the intestine. The expression levels were automatically scaled to a 5-year-old child. So really all I needed to do was change the physiology and change the dosing. I will want to compare the prediction. In this case, we actually have the data from a study. I will want to compare the prediction with the observed data. So let me load the file. And I'll do a very quick load. I named it differently. This data may seem a little odd here. What you are looking at here is a scatter point of the individual sampling points from the children in the study. The study used, I think, about 20 children or so. I can remember the details of how many exactly were there, but they were sampling only about 2 or 3 data points per child, and we have the data combining all of them together. So I'll save this file to have it associated with my current record. And now when I run a simulation, maybe 6 hours will be sufficient. You will see that the predicted PK profile, the blue line, is going roughly through the middle of all of these individual points. Right? The study included children from 1 to 12 years old, and the 5 years old was the average age. So we would expect that PK for the 5-year-old child to go through the middle of these data points. So now the next step, what would we do if we actually wanted to model a study of which includes children of 1 through 12 years old? This is where we could use a population simulation. I'd go into Simulation tab, click on Population Simulator, and by default, the program selects all the parameters that could actually vary from one child to the next to start creating variability in the population among different subjects. If I click on Set Pair, this pair stands for Population Estimates for Age-Related Physiology. This is where I would define what my population is going to look like. And I'm going to sample from the same population of Western children. For health status, this is where you could select either healthy, hepatic impairment, renal impairment. You can define what proportion of males and females approximately you would like to have in your study. Then you'll define the age range. And in this case, to reproduce the study, I would like to go from 1 through 12 years old. And you can also define the body weights or BMIs that you would like to have within the study. Right? So this allows you to more narrowly define the population that you are actually trying to simulate. In this case, I'll leave it at the body weights within about 15% of the typical body weight. For children, it might be better to define the body weights as a percent of the body weight rather than absolute values. And I'll keep the default for BMIs, but again, depending on what population you are trying to simulate, you could define the age, the BMI range to have your PK or the simulated subjects, virtual subject, better representing the population you're actually trying to match. I'll click OK here. And that defines the population I want to create. The next step that I want to do also in this study is simulate the dosing. The dosing in this study was 0.1 milligram per kilogram. Right? So I would change the dosing into milligram per kilogram. And in here, I will define it was actually 0.1. So it wasn't the same dose given to all children in terms of the absolute dose, but it was scaled by kilogram. And you do have an option to define that dosing either per kilogram or per body surface area within this population simulator. So this much for the setting of the population. And then on the simulation tab here, you would simply need to define the sample size, how many virtual subjects you'd like to have in this study. And you can go up to about 2,500 subjects. In this case, I'm going to keep it simple, and I'll keep it only at 25 subjects to just give you an overview or a small taste for what the outputs would look like. I'll click Start. The program suggests the output name to keep all details for the population, and we'll take a quick look at it when the simulation is finished. I'll click Save. And this is where the program is simply giving you information about how it will be making adjustments on different parameters. And now it is doing the simulations through individual patients, right? Creating individual virtual patients. So while it's running, I'll go quickly back to the slides to give you a quick description on what that population simulator is actually doing in the background. Right? And it is not perfect yet. There is a lot of parameters for which the covariates are not well known or defined yet, but we do have them defined for the parameters where we were able to find these relationships, things like links between tissue sizes, body weight, height, BMIs, and so on. So what the program actually does, right, from that population that I defined, right, I told the program that I want 25 children in ages 1 through 12 years old, and I want about 50% of them to be males. So it is a multi-step process to create each virtual subject, and the first step is from this definition, select an age and gender. So maybe the program randomly selects that my first child will be a 2-year-old boy. It creates for the 2-year-old boy, it finds a body weight, right? It knows what would be the distribution of body weights and body heights for the 2-year-old boys, right, within that population. So it randomly selects the body weight from that distribution. And then based on the relationship between body weights and heights, it takes into account the age, gender, and now selected body weight to select what would be a body height, what would be appropriate height of that 2-year-old boy for the body weight that it selected. Okay. And based on these specifications, it now has enough information to create a whole physiology, to create the sizes and the blood flows for individual organs. Okay. And these are related to, could be related to any of these parameters or multiple parameters between age, height, weight, BMI, body surface area. And it really depends on which tissue it's dealing with. The sizes of some tissues correlate more with the body weight, other tissues with the body height, some tissues correlate more with body surface area, and all of these algorithms are built in. So this way it is able to generate these virtual subjects, and it just repeats this process as many times as many subjects we had. This is a sample showing of some validation. This was a sample case showing the population created where we let the program really run wild. This was creating 500 subjects, 2 to 40 years old, 50% males, but we gave it a very wide range of body weights and the BMIs. And with these very wide specifications, it actually did generate a population with the very different body weights. There is usually less variability on body height, but also individual tissue sizes. There would be high variability in the different tissue sizes. Okay? But through those specifications on body weights and BMIs, you do have an option to narrow it down to the specific population that you want. So let's say if I wanted to model patients or subjects that are close to the ideal BMI, right? I select, so from that population, the second run was simply taking 50 subjects with BMI only up to 21. And now the program would be creating only subjects with lower body weights. These patients would be typically taller, right? And the individual tissue sizes would then represent the physiologies, the relevant physiologies for those patients. So you do have a better control over a population that you are trying to create. I did hear a little ding there, so the population simulation has finished. And at the end of the simulation, the program summarizes here what was the mean, CV, minimum, maximum, geometric mean of the standard simulation in outputs like fraction absorbed, dose to portal vein, bioavailability, Cmax, Tmax, and AUCs. If you look on the graph and the new plot window, this is where you would see overlaid simulation results with the observed data. The dark line is showing here the average CP time profile across those 25 patients. The green field around it is showing the 90% confidence interval across those 20 on the mean across those 25 patients. If I click probability contours or percentiles, this is now showing me the individual or the all of the simulated profiles, the percentile, the probabilities on all of the simulated profiles. And you can see that the variability in the simulated population is a little bit wider than the observed, but it is nicely encompassing the entire population. It actually nicely represents the variability in the real population of patients. And if you want to see what that population actually looked like, all of that information can be, I should have had this ready. The output file, it is a simple output file that can be formatted for Excel output, where you can see all the details of how those children were generated, and in that output you would see exactly what was the age, weight, height for each of the child, was it male or female, and so on. So all of the details are available to you. So that covers the pediatrics, showing just a few additional studies that we've done over the years, but for the sake of time, I'll move into the next step, looking into the disease conditions. And I think this might be a good time for the next poll. Arlene, do you want to launch that one?
Sure. Thank you, Viera. Good stuff. Okay, so a quick question to the audience. Were you aware of the GastroPlus capabilities in modeling special populations? We'll give you 30 seconds. Submit your answers now. Okay, so it looks like a good percentage of you are aware of the GastroPlus capabilities that Viera is reviewing. We'll continue through with the disease conditions. Go ahead, Viera.
Okay. So again, why do we want to model these is to start replacing the studies, right? So that you don't have to do unnecessarily extra experimental studies in patients who may have some organ impairment and might be better off to start taking actual real drugs rather than doing preliminary test studies. And within GastroPlus, the built-in physiologies for these disease conditions currently include the liver impairment, renal impairment, as well as obesity. So I'll go right into it, just a brief description for the liver impairment, right? The liver impairment or the disease progression goes through several different stages. The early stage, where the liver undergoes some inflammatory damage, early fibrosis. This is typically a reversible state. It can be treated. The next stage would be going into the disruption of the liver architecture, losing the function, right? Creating more significant damage. And finally, again, if not treated and reversed or stalled, it would proceed into a complete liver failure requiring liver transplant. And to characterize these different stages of the liver impairment, what we are using is the standard Characterizing score, which classifies the degrees of this disease severity from the A stage, which is compensated liver disease. You may not even see much of a effect on the actual PK of the compound or the function of the liver, going through stage B, where you see significant compromise of the function, up to the C level, which is now decompensated and leading to a liver failure. This was the first physiology that we implemented. It was the simpler one for us because by the time we got to it, there have been already a number of publications summarizing the physiological changes due to different stages of liver cirrhosis. And as you would expect, these do include the functional liver volume and the expression levels of the enzymes in the liver. But it's not only about the liver, especially as the disease is progressing. This is becoming more and more of a systemic condition where other physiological parameters get affected. The protein levels are going down, the hematocrit is changing, so all of these are affecting the distribution in the blood. Cardiac output is changing, blood flows through the tissues, also through portal vein is changing, affecting the distribution of the compounds. Even GFR is changing, right? So even renally secreted compounds can be affected by liver cirrhosis. So all of these parameters do need to be taken into account. And in GastroPlus, we did incorporate these physiological changes for the different degrees of liver cirrhosis. For the chronic kidney disease, again, it is classified, and the classification that we are using is the chronic kidney classification, the standard one, based on the GFR, right, with the GFR more than 90 mL per minute per 1.73 square meter. It is assumed to be normal kidney function, 60 to 90, mild damage, 30 to 60, moderate damage, below 30, looking at the severe damage, and less than 15, looking at the kidney failure. And so this is the standard classification. But similar to the liver disease, it's not all about kidney. The other systems, the rest of the physiology will also become affected, and more so with the later stages. So the more the kidney becomes damaged, the more these effects start being pronounced or start showing up in the other systems as well, including expression levels of the enzymes in the liver. Again, plasma protein binding, hematocrit is changing. There were also studies showing that the gastric emptying time is getting longer, so the gastric emptying is slowing down with the renal impairment and so on. So again, as much as we were able to find in literature, we have incorporated these different changes to account for the different degrees of renal impairment. For the obesity, again, we are using the standard classification to just classify what physiology was created, but this is more of a continuous scale. So you can create a physiology with the different body weights and BMIs, as I was showing a little bit earlier, and the program automatically accounts for how the different tissue sizes or how the different tissues will be affected in those conditions, and how the contribution, how sizes of different tissues are changing at different rates, right? Some of the tissues will get bigger in obesity, other tissues will remain at about the same size as in a non-obese subject. So all of these algorithms are accounted for within the physiologies. So to show you, how to quickly set these up, I'll do at least an example for liver cirrhosis. And I will continue here with my midazolam example. where again we've shown earlier the model that worked nicely for healthy subjects. So we'll create this. We are going to use this to start predicting the PK in liver cirrhosis. And I'll do a couple of these stages. We do have data from a publication for stages A, B, and C for liver cirrhosis. I'll go to only a couple of those. The data came from a publication describing the populations for each stage. So again, to start predicting liver cirrhosis, I'll start with my healthy patient or healthy subject record. I'll create a copy of it. And let's say we'll do the CPA and C. Maybe we'll do the mild and the severe liver cirrhosis. So I'll call this record adult CPA IV 1 milligram. And from the publication, we already created the support file containing the plasma concentration time profile for these patients. As you might have guessed from the previous example, the changes I need to make is change the dose. Here these plasma concentration time profiles were normalized to 1 milligram dose. And we'll change the physiology. So instead of a healthy subject, we'll create a subject with the CPA or the Child-Pugh score A with the liver cirrhosis. So I'll again go to new PBPK. And in this case, we do have the more detailed specification for the physiology. So I will use the actual age and weight for the patients. Right? And you can see within this group, they had more males than females. So I'll stick with a male physiology. The average age was 56 years old. So I'll create 56. Actually, they are not healthy. We have on cirrhosis CPA. Right? And the average body weight within this group was 91 kilograms. So it is close to the typical body weight, but we can adjust it to 91 kilograms to matching the population or the group of patients more accurately and create the physiology for these subjects. If I click OK, again, the hematocrit and plasma protein levels are changing in the disease condition. So I want to recalculate the tissue plasma partition coefficients to account for the changes in the distribution into tissues. And one thing that you would notice is that the distribution into tissues is actually increasing. Less drug is being bound in the plasma, more is available to go into the tissue. So the volume of distribution actually is going up. And at this point, we'd be ready to run a simulation. So, or run a prediction. Again, the physiologies are automatically adjusted. All the information that we were able to find in the literature, the enzyme expression levels and so on were adjusted. So I can simply run the prediction for the PK in this mild liver impairment. And just for a later comparison, right, you would see that the initial prediction in healthy subjects was very accurate, and we are also getting a very accurate prediction now in these patients with the mild degree of liver cirrhosis. Now, how would we do as the disease is proceeding? So I'm going to try to do the late stage. If I copy this record, copy drug record, create it for stage B. Sorry, actually, I'm going to stage C, right? That's what I said. Again, we do have the data for the stage C of liver cirrhosis. So what we need to do is create a physiology for this group of patients, right? And in this case, they had 10 males about average age 55 years old, average body weight 85 kilograms. So similar as earlier, I'll create a physiology for these patients, kid male, CPC. And if you were doing this for, let's say, renal impairment, it would be similar strategy. Generate the physiology, but select from the health status for the different degrees of renal impairment. If you wanted to do this for obese patients, which doesn't, if they don't have any other comorbidity, we would keep it at healthy and simply modify the body weight or BMI to account for the obese patients. In this case, we are looking more at the liver cirrhosis. It's 55 years old male, 85 kilograms. Have the program rescale the whole physiology, click OK. Again, you would see that in these patients, in the later stage of the liver cirrhosis, the hematocrit and plasma protein levels go down even further. Right? We are down to only about 60% of the plasma protein levels. So the fraction unbound in plasma is significantly increasing, and this will be affecting the distribution. And if you watch this VSS, so if we use the KPs as calculated for the mild liver cirrhosis, the volume of distribution would be 91 liters. But if we recalculate it for the late stage, it goes up to over 100 liters. So this is something that also affects the prediction of PK. And if I run the simulation, you will see the AUCs again are starting to observe data nicely. If I put it on the plot here, and maybe I'll make sure that the scales are similar or are the same, and I can zoom in a little bit better going for each of these so that you can better see the difference between the mild stage and the severe stage. Right? You can see how the observed PK and also predicted PK nicely accounted for these changes in the pharmacokinetics of midazolam, or at least IV midazolam after administration, or in the different stages of the liver cirrhosis. Okay. To look at how the effect would be on, let's say, intestinal first pass metabolism, we can do also a quick simulation for oral administration. We do have the data from a different study also where the subjects got oral solution administration, 15 milligrams, and these were on average about the moderate liver cirrhosis. So again, I'll go into maybe my 15 milligram PO record, create a copy, adult CPB PO solution 15 milligram. And for those of you who have attended yesterday's webinar, I know that Maxime have gone through an explanation of how to name these records, right? You typically want to have a good name so that you can easily distinguish the different simulations that you've done, right? So I have here adult, IV, and PO. I have here one for pediatric. I have adult, different degrees of liver cirrhosis. So it does make sense to put a little thought into these namings so that you can easily find the record that you want to simulate. The dosing remains the same. It's 15 milligram solution. All I need to do is change the physiology. And in this case, the average subjects were 48 years old, 85 kilograms. So again, I'll create a physiology representing that study. This will be mild liver cirrhosis. It's actually close to the typical body weight. Oops, so I need 48 years old. 48, 85.1 kilograms, CPB. Click OK and yes. Everybody probably can guess the next step, recalculate KPs and run a simulation. should run it a little bit longer. In this case, they were capturing the data for a longer period of time than in the healthy subject. And you can see that it predicted very nicely the PK. For easier comparison, I'm going to rerun the 15 milligram in a healthy subject. This was from a different study, right? But to show better the changes in the PK. So on the left, we have healthy subjects. On the right, we have subjects with a moderate degree of liver impairment. And you will see the AUC and Cmax both went up in healthy subjects. It was about 150, both observed and simulated, very nicely matching. In liver cirrhosis, it went up to closer to about 500-600, right? And very nice match. The Cmax increased a bit as well, right? Nearly doubled. The other thing that you would notice is that the fraction dose to portal vein, you may remember, those of you who attended yesterday, fraction dose to portal vein, or the difference between fraction absorbed and dose to portal vein accounts for metabolism in the gut, right, in the intestine. And you can see that in healthy subjects, about 48% of the drug at this dose got metabolized in the intestine. In the patients with the moderate liver impairment, it was only about 35%. So again, even the enzyme in the intestine got affected and accounted for lower metabolism, and the rest of the changes in AUC would be caused by the metabolism in the liver. So that was a very quick example of how to do physiology or how to start doing predictions when you have the built-in physiologies, or when you want to use the built-in physiologies for liver cirrhosis. Again, similar process you would use for renal impairment. So the final stage for the last few minutes go over our latest development on the pregnant women, right? So looking at the pregnancy, this is where the development was a little bit more involved, because it wasn't only about changing the physiological parameters like tissue sizes, compositions, enzyme expression levels, right? But it required adding a whole new body, right, representing the fetus, and adding new mechanisms to account for the drug exchange between the physiology of the mother and the fetus. And here currently, we are using a simplified fetus model where we are representing the placenta, amniotic fluid, and the fetus is represented by a single tissue compartment. In the future, we'd be extending it to represent also multi-tissue model, which would be relevant especially for the late stages of the pregnancy, but for now we are using this more simplified model. And these mechanisms account for, or the new mechanisms that we needed to add was the drug exchange between the amniotic fluid and the fetal blood flow within the placenta, between amniotic fluid and the uterus, the drug movement through the fetus, swallowing, secretion, urination, right, as it's and the drug exchange between the fetus and the amniotic fluid that way, right, as well as the transplacental drug exchange between the maternal and the placenta and the fetal placenta. So for the amniotic fluid volume, there is a fairly tight regulation of this volume of the amniotic fluid, even though the mechanisms are not completely or understood in a great detail. There are multiple pathways that account for this regulation, and the general mechanisms accounting for the drug exchange would be the intramembranous, transmembranous pathway, and the fetal pathway. So the intramembranous pathway is the movement of water and solute that occurs between the amniotic fluid and the fetal blood flow within the placenta. And this could be passive, simple diffusion based on concentration gradients, or it could be active, more of a vesicular transfer, or more of a convective flow. The transmembranous pathway, this is movement of water between solute and movement between the amniotic fluid and the maternal blood flow within the wall of uterus. Okay, so the wall of uterus would be up here in the picture. So this is especially important in the early gestation, where the other pathways are not well mature yet. So in the early gestation, this would be the dominant process. And finally, the fetal pathway, it is movement of drug or water and drugs between the amniotic fluid and the organs of the fetus, right? And these accounts again for the different, basically the swallowing, urination, and the reabsorption or the absorption of the drug into the fetus through those processes. I'll skip through some of these slides. Just for the sake of time, we can come back to those if there are significant questions on that. But so in this case, of course, if you need to model, there will be additional physiological specifications that you'll need to make. One is defining also gestational age, right? In addition to defining the age of the mother and the body weight, you need to also define the gestational age and the fetus gender, right? And again, the program automatically generates what would be the typical body weight. And right now we actually have two different models for the first 6 of gestation, where the fetus is fairly small, so it's not contributing much to the drug distribution. And we basically just adding a uterus compartment. Or after 6 weeks of gestation, where now fetus becomes more significant, has a heartbeat, so we do need to account also for the blood flow through the fetus, and are including the additional compartments for the fetus, placenta, amniotic fluid, and so on. This would be also accounted for in the population simulation. Right? In one of the earlier examples, I showed how you can create a population simulation for different patients. With the pregnant population, with the pregnant women, you can also have the variability now on the gestational age, fetus weight, and fetus specifications. Similar plots that I was showing previously for the children or for the infants, these were extended to account for the physiology of the fetus itself. The one parameter that is also important is the pre-pregnancy weight. So the algorithms do need to know what was the pre-pregnancy weight of the mother, as well as what was the weight gain, to properly account for the changes in the tissue sizes for the mom as well as for the fetus itself. And I think we have another minute or so to do a quick example on the midazolam again for the pregnant women. Here we'll do actually 2 simulations from the study from which we got this data. They've done the PK in postpartum, or actually done the pharmacokinetics of midazolam during 30 weeks of gestation, at the 30 week of gestation, and but also at postpartum. So first I'll do the simulation at postpartum to see if there is any significant variability in the PK between all the populations or the simulations I've been doing so far, and we will be using those as sort of an internal calibration to then simulate what was the PK within those females during the pregnancy. So again, I'll create a copy of this record, copy drug record. In this case, the administration in this study that we are trying to reproduce was a tablet. We'll set the 2 milligram tablet. Okay. And we need to create a female physiology for this, and we'll be creating a healthy 28 years old, about 71 kilogram body weight. Again, we'll recalculate the KPs for these to run the, oops, I must have mistyped, so let me load the OPD file so that we can compare the observed data. This one. And so this is the PK that we obtained from the literature. And these females postpartum. And what you would see in this case that here we are actually under-predicting the PK a little bit, and actually it seems like significant change, but this could actually be simply due to the changes in the enzyme activity. And you will see that if I change enzyme activity or expression levels, I'm going to do a simple modification through Vmax. And the standard or the in vitro value was, so these were in vitro values for the pharmacokinetics. The Vmax was about 1. If we bring it down by 30% only, so using Vmax 0.7 nanomole per minute per milligram protein to adjust the pharmacokinetics or to adjust the activity of the enzyme in these non-pregnant women. Okay. In this group of non-pregnant women, you can see we are getting a much better match. And the 30% difference in the enzyme or the enzyme expression levels would be well within the range of variabilities on the observed enzyme expression levels. So nothing unusual. So once we have the model calibrated to account for the clearance in these females when they were not pregnant anymore, right? Now we can see what would be how well the model would predict the PK during the pregnancy. So I'll make a copy of this record, and I'll call it about 2 milligram tablet 30 weeks. The dosage was the same, 2 milligrams. All we need to do is create a physiology now for these pregnant women. They were still 28 years old, but we need to select pregnant physiology. And in this case, we need to define what was the gestational age, and we want to do 30 weeks. The pre-pregnant weight was 76.4 kilograms. And the weight gain within those 30 weeks was 9.2 kilograms. So we'll define 9.2 here. And again, both of these are important in order to correctly define the physiology or the tissue sizes for both the mom as well as the fetus. Create the physiology. If we take a quick peek here at our PBPK model structure, you will see that now we have here connected the body for the fetus through the placenta, right? So again, we can recalculate the KPs to account for the changes in the protein levels, hematocrit, and so on, and do a prediction for these females at the 30 weeks of gestation. And what you would see and I'll do this on a separate plot, again, just so that we can compare side by side, that the predictions are not perfect, right? This is realistic situation. Not every prediction will be as perfect as what you were seeing before with the pediatrics and with the liver cirrhosis, right? Sometimes there will just be a bit of a misprediction, but you can see that the model very nicely accounted for or very nicely predicted overall change in the PK. It nicely predicted that the Cmax would go down, even though it predicts a little bit bigger decrease than was observed. It nicely predicted that the AUC would go down to about half of the one in non-pregnant women. Right? So still very useful, a useful simulation and prediction. And with the pregnant women, you can also start looking at the PK not only in maternal tissues and plasma concentrations, but can start looking also at the pharmacokinetics in the fetus, in the amniotic fluid, whatever PK you might need to be relevant for your compound. This is additional example. I think I'll skip that one for the sake of leaving at least a few minutes for the questions. It was an example where we were validating the pregnant physiologies using compound, where different processes important. In this case, it was cefazolin, which is eliminated by renal secretion. So a few p times GFR, as well as the active secretion were included. The model was parameterized in healthy subjects, actually males, and then used to predict the different studies in pregnant women. And you can see that the studies were nicely predicting the PK, as well as the PK in the neonatal plasma, as well as in the amniotic fluid. So to sum it up, GastroPlus includes already a number of built-in physiologies for special populations, but you are not limited to only the ones that I've presented here. Right? You don't have to stick to only the built-in ones. The flexibility of the program, where you can go edit PBPK, you can modify these physiologies. So you can start creating your own special populations or special physiologies. All it comes down to knowing what physiological changes you expect in the condition that you are trying to simulate. And with that step, our scientists would be happy to help you, guide you through how to make those modifications. And I guess that's the time for the last poll question that we have here.